Hello. This is the ARDS study notes. The topic of this note is the clinical evidence for prone position ventilation in ARDS management. Prone position ventilation is one of the strategies to reduce heterogeneity and increase homogeneity in ARDS lung, which maintains mechanical ventilation while the patient is in a prone position. The first report of the effects of prone position ventilation in adults was in 1976. In a study involving 5 patients with severe respiratory insufficiency requiring ventilator support, a specialized bed called the circ electric bed was used to achieve prone positioning. As a result, the arterial blood oxygen concentration, which was an average of 82 millimeters of mercury in the supine position, increased by an additional average of 47 millimeters of mercury after the prone position, significantly improving the patient's oxygenation. The authors judged that the improvement in the ventilation-perfusion ratio was the underlying mechanism. Since then, many studies on prone positioning have been conducted, and the following scientific rationales have been proposed. As is well known, ARDS lungs are characterized by severe consolidation, congestion, and inflammation in the dependent part, leading to the collapse of alveoli called the telectasis. In such a state, when the prone position is assumed, primarily due to the redistribution of water, the alveoli on the backside of the lung are recruited and aerated, which is the main rationale. Additionally, in the supine position, a significant portion of the lung is restricted in its respiratory movement due to the weight of the heart. However, in the prone position, the areas restricted in respiratory movement are minimized. As a result, the overall homogeneity of the ARDS lung improves. An increase in end expiratory lung volume and ventilation perfusion matching, regional changes in ventilation, and alterations in chest wall mechanics occur, resulting in an overall decrease in ventilator-induced lung injury. Despite such scientific rationale, there has been considerable controversy regarding the impact of prone position ventilation on the mortality of ARDS patients. The first multi-center randomized trial, the prone supine study, was reported in 2001, which showed that while oxygenation improved, but mortality did not. The prone supine study was conducted around the same time as the ARMA study, which reported that low tidal volume improved mortality in ARDS patients. As a result, the prone supine study had a significant limitation in that it did not apply the low tidal volume that could improve patients' mortality. However, subsequent studies, including those applying low tidal volume, showed the same results. The prone supine the second study, which considered various limitations and reflected post-hoc analysis results of previous studies, was reported in 2009. Unfortunately, it also found no impact on mortality, causing clinical expectations for prone position ventilation to significantly decrease. Amidst this, a systematic review and meta-analysis of previous studies were published in 2010. One of the most significant findings was that prone position ventilation might reduce mortality in patients with severe hypoxemia, indicated by a PaO2-FiO2 ratio below 100 millimeters of mercury. The randomized controlled study that proved this analysis result was the PROSEVA study, published in 2013. In fact, the PROSEVA study began in January 2008, so it cannot be said that the analysis result of the systematic review and meta-analysis published in 2010 was the direct cause of the study's initiation. Rather, it is more accurate to say that a similar possibility was first suggested in the post-hoc analysis of previous studies. The PROSEVA study investigated the effects of prone positioning in severe ARDS. Upon examining the study in detail, patients who met the previous ACC criteria for ARDS with a PF ratio of 200 millimeters of mercury or below, and received mechanical ventilation for less than 36 hours were included. Among these patients, even after 12 to 24 hours of mechanical ventilation, those with a PF ratio of less than 150 millimeters of mercury at FiO2 levels of 0.6 or higher, and PEEP levels of 5 centimeters H2O or higher, were enrolled. An important but often overlooked aspect is that, when looking at a related study supporting the meaning of these enrollment criteria, the effects of PEEP and FiO2 applied in the early stages of ARDS management can reflect the degree of lung injury. In this study, 170 ARDS patients with an average PF ratio of 128 millimeters of mercury received mechanical ventilation under conditions of PEEP higher than 10 centimeters H2O and FiO2 of 0.5 or more. 1 day later, 99 patients remained with a PF ratio below 200 millimeters of mercury, while 55 patients improved to acute lung injury non-ARDS, with PF ratios between 200 and 300, and 16 patients had PF ratios exceeding 300. In other words, patients whose PF ratios remained below 200 millimeters of mercury were considered to be in a much more severe state than those who did not. Therefore, it can be concluded that these enroll criteria in the PROSEVA study represent a very severe ARDS condition. Moreover, while previous studies set the enrollment time at around 72 hours, the PROSEVA study enrolled patients very early, within 36 hours. Additionally, prone positioning was implemented for a minimum of 16 hours per day, for up to 28 days as a prolonged period. As a result, the not adjusted and adjusted for SOFA score 28-day and 90-day mortality rates were significantly lower in the prone group compared to supine group. Furthermore, other clinical parameters including successful extubation rate at 90 days, length of stay in the intensive care unit among survivors, and ventilator-free days were significantly improved in the prone group. Therefore, the study concluded that early and prolonged prone positioning in severe ARDS patients significantly reduces mortality. Consequently, the clinical significance of prone position ventilation has been greatly elevated through the PROSEVA study. Based on these results, the 2017 ARDS mechanical ventilation guideline strongly recommended applying prone positioning for more than 12 hours per day in severe ARDS patients, with a moderate high confidence in effect estimates. Furthermore, it was recommended that implementation strategies be developed in all centers treating severe ARDS patients to apply the results of the PROSEVA study. Subsequently, the 2021 Surviving Sepsis Campaign Guideline and the 2019 UK Guideline recommended prone positioning more broadly for moderate to severe ARDS patients. The French guidelines made the same recommendations as the PROSEVA study protocol. So, to what extent is prone position ventilation being implemented in clinical practice? According to the APRONET survey, conducted about 3 years after the PROSEVA study was published, only about 1/3 of severe ARDS patients received prone positioning, indicating that efforts to actively implement prone positioning are needed. Adequate critical care staff, especially nurses, are essential for the active implementation of prone position ventilation. However, most centers lack sufficient staff, resulting in many constraints in implementing prone position ventilation. Another concern in performing prone positioning is the occurrence of adverse events due to positioning. In fact, clinical studies and meta-analyses have reported the occurrence and worsening of pressure sores, increased use of sedatives and muscle relaxants, hemodynamic instability, device displacement, and obstruction of endotracheal tubes. However, the PROSEVA study's report defied these expectations. There was no difference in the incidence of complications between the groups, and there were no adverse events directly related to repositioning. The most important reason for this is believed to be that all centers participating in the study had already been performing prone positioning as a daily routine practice for more than 5 years and were highly experienced. This fact suggests that the more familiar one is with changing a patient's position, the more likely they can avoid related side effects. This is the clinical evidence on prone position ventilation and ARDS management. Thanks for your listening.